thank you very much for this very kind invitation. It's a pleasure for me to be here, and it's an honor as well. So when I show you this slide, I have 10 seconds, as you see, because of course I have no conflict of interest. IQWiC is an independent scientific organization which doesn't have any relationships with stakeholders, of course not with the industry. We are fully covered by fees by the German citizens who are insured by the statutory health insurance system. So this for this disclosure. I think I just learned from the first two presentations that if we are talking about evidence, real-world evidence, we are talking about very different things, and that is one topic of one problem of this issue. And I will show you a view which is very, very different from that what we just have heard. And the second I want to mention before I start with my presentation is I just learned that there might be some drugs where we know that they are better than what we already have before we have any clinical trial. So this is, I'm a little bit in doubt, and if this would be the case, it would be hard for me because I would be unemployed. So, I might have a...
We'll talk about it later.
Okay, there I might have a conflict of interest. Okay, let's start. So the first thing I want to emphasize is that we, from a health technology assessment perspective, we have a very different view on things in comparison to the approval. And so the most important differences to drug approval is that we are looking at the added benefit of new drugs. That means we compare the new intervention, the new drug, with what we still have in our system. That means comparison to the best available intervention so far. This is not the duty of the approval, and we focus on patient-relevant outcomes. And there may be institutions, not IQWiC at the moment, which look at cost-benefit analysis and cost and ethics and societal effects. So the result is that if a drug has been granted approval, this does not mean necessarily that it's an improvement over the standard of care. This you should please keep in mind. It may even be worse. So, and this is our task, to look whether the new is better than the old. So when I'm a physician and I'm a clinical epidemiologist by training, and I have some experience in clinical trials. And when I learned how to conduct clinical trials and how to analyze clinical trials, I learned this differentiations in four phases, and the most important phase is phase 3. And these figures here, these numbers, coming from the US Association of Pharmaceutical Companies, I think this is very unsuspicious. And what I would like to pay your attention on these figures in phase 3. That means phase 3 studies, pivotal studies, are studies with 1,000 to 5,000 patients in the past. This was what I have learned, and which is also still actual in 2015. So please remember this figure. So about 20 years ago, there started some movement for accelerated and facilitated approval. First was the legislation in Europe with the orphan drugs. Then came legislation with exceptional approval under exceptional circumstances. Then we had the conditional approval. And now very new is a priority medicines initiative from the EMA, and the future may be adaptive pathways. So if you look at our current knowledge about new drugs in oncology, this is an investigation from 2015, then you see that in the pivotal studies, in regular approved drugs, we have just 600 patients. Not 1,000 to 5,000, but 600. And in drugs who got their approval conditionally, we have just 154 patients per trial for the pivotal trials. And this is the whole trial. That means usually only half of these 150 patients were exposed to the new drug. 75 patients were exposed to the new drug, and then they got their approval. This is, I don't know whether it's really a good development. So from a health technology assessment perspective, so this is an example where I think we have rather good data, because we have a trial with about 900 patients, which is more than 600. It's less than 1,000 to 5,000, but it's more than 600 or even 150. We have a clear advantage in overall survival, but we have also an advantage in patient-relevant outcomes here, for example, in health-related quality of life, or in terms of avoiding of adverse events, for example, the hand-foot syndrome. So these are rather good data. And here are rather weak data. Here the approval is based on a phase 2 study with 200 patients. And the approval was granted by means of a surrogate endpoint. And in 2016, there was a publication where they showed that there was no statistically significant difference in disease-free or overall survival after a follow-up for 5 years. And the drug was connected with statistically significant disadvantage with respect to discontinuation of study drug. And we don't have any data on health-related quality of life or other patient-reported outcomes. So this is from an HTA perspective rather weak, or we could say very weak. So now we are in the situation where we have only very, very limited experiences in clinical trials for new drugs, especially in oncology, especially under conditional approval or conditionally approved drugs. And now we have this new initiative from the EMA, from the European Regulatory Authority, which is called Adaptive Pathways. And there they want to establish an approval which is regularly based on this conditional idea and using surrogate endpoints, and then the idea is to gather further evidence through real-life use. So, and usually people mean, if they are talking about real-life evidence, about evidence from the observational studies, from registries, from cohort studies, and so stuff. So I give you now an example why I don't think that this is a good idea. This is a publication, it's 10 years old or 12 years old, from a very famous or very important medical journal in the US, the JAMA. And here is an analysis of the SEER database and prostate cancer, comparison of active treatment versus observation. And here the important outcome was overall mortality. And what you can see after 12 years, there was a clear reduction in mortality with the use of active treatment. And they saw similar results after statistical adjustment for possible confounders. It's an observational study, of course. And they saw similar results for prostate cancer-specific survival. So far, so good. But now comes the clue. 90% of all deaths were not due to prostate cancer. So I ask you, how can prostatectomy reduce risks for death by, e.g., heart disease or pneumonia or even other cancers? That's impossible. So this result is nonsense. It's totally nonsense. But it's published in a very famous journal. So the authors, so what is the explanation? Observational data, here real-world evidence in terms of observational data, are inherently and severely limited by selection bias, which cannot be controlled by any statistical method. Forget statistical methods here. You cannot control for selection bias. It's impossible. So, and the conclusion of the author was, okay, we saw this very impressive reduction in mortality risk, but this is, you nearly always find this sentence, these results must be validated in randomized controlled trials. Okay, different example. Here, bevacizumab in metastatic breast cancer as addition to paclitaxel, and the authors in this publication wrote that we need real evidence studies and that they are increasingly important as complementary tools for describing drug effectiveness and safety over the entire product life cycle. It's a very nice word, product life cycle. I hate it. So, okay, it's very important, the authors say. And now the results. Again, observational data. Again, very impressive. They prolong the survival time by about 1/3, 8 months. And the results were consistent. All supportive analysis, all sensitivity analysis gave the same result after adjustment with propensity score or after matching or nested case control, whatever you need, always the same result. And then, in the conclusions, the authors state this. In this large-scale, real-life setting, real-life data, they saw this significantly better overall survival. But, despite robust methodology, real-life data are exposed to important potential biases, and therefore results need to be treated with caution. Our data cannot therefore support extension of current use of bevacizumab. This doesn't make sense. This doesn't make sense. This is waste of money, if this is a conclusion. Okay. History repeats itself. Maybe you know that about 25 years ago, there was a movement in the US which they called outcomes research. And for this movement, they spent about more or less $200 million US dollars. Again, the use of observational data for questions of effectiveness. So, the result was nothing. Again, it was nothing. Richard Peto, a very famous UK epidemiologist, this is his conclusion. It has utterly, totally, and predictably failed to do anything. $200 million were wasted. So, these are my conclusions. Do not confuse approval and HTA. This is very important because we have sometimes people who say, oh, this drug is approved. It must have a benefit. Yeah, it may, but it must not have, or it may not have an added benefit. Please do not confuse innovation and improvement. We see that our knowledge about new drugs decreases with every new approach of accelerated or facilitated approval. And I think this is important, and this is I think this is what you just talked to us. Real-world data may be used to describe what happens in everyday clinical practice in the sense of what is done compared to what should be done. That means in a mean of quality management. I think this is a fantastic way. But if we are talking about causation, it's causation stupid. Real-world data have no role if added benefit or benefit at all is to be assessed. And please do not repeat the mistakes from history. I thank you for your attention.